Hey everyone, and welcome to today's Explainer. We're jumping right into the stark realities of Alberta's 2026 pharmacy funding framework and the documented operational crisis that's currently hitting local pharmacies. We're going to be looking at this data specifically from the perspective of frontline advocates who are speaking directly to government policymakers. Basically, our goal today is to unpack the glaring gap between the government's stated policy objectives and the actual on-the-ground reality that's unfolding in practice right now. So let's dive into this. Is the 2026 framework actually stabilizing healthcare? Well, if we contrast the government's promise of multi-year stability against the actual data from the front line, things get a little complicated. The government and the Alberta Pharmacists Association finalized a framework that's supposed to provide stability all the way through to March 2029. And honestly, it sounds great on paper. Official releases talk a lot about ensuring sustainability and recognizing the essential role pharmacists play. But when we look at the actual evidence, specifically a recent impact report that surveyed 184 practicing Alberta pharmacists, a very different and honestly much more alarming narrative emerges. Look at this number, 82%. That is the percentage of surveyed pharmacists who are reporting that their margins are tightening or that their viability is completely at risk under this new framework. That's over 4 out of 5 pharmacists effectively waving a massive red flag about the survival of their practice. On the flip side, only a tiny 3% report that they're actually thriving. You know, when an overwhelming majority of your healthcare delivery backbone is telling you that the math literally no longer works, it absolutely demands immediate attention.
Section 1. The operational margin squeeze. Let's look exactly at what is creating this immense operational pressure on your local pharmacies. So the government did introduce a dispensing fee increase for standard prescriptions, which sounds like a step in the right direction, but it amounts to just 20 cents. Now, while this was technically the first increase in over a decade, advocates are quick to point out that this 20-cent bump completely struggles to keep pace with Canada's inflation rate, which has compounded to roughly 24% since 2010. For an average pharmacy dispensing, say, 100 prescriptions a day, this translates to maybe a few hundred extra dollars a month.
The disparity here is just wild when you place those meager new fees right next to soaring operational costs. Over just the last 3 years, the cost of labor, paying technicians and support staff, has skyrocketed by up to 25%. Rent and occupancy costs, they've jumped 15 to 30%. And that's not even mentioning utilities, insurance, and the thousands needed for basic compliance technology. A flat 20-cent fee increase stacked against a tidal wave of operational inflation means that independent pharmacies are essentially operating at a loss on their core services.
Furthermore, the new MML, the Maintenance Medication List, requires pharmacies to dispense 84 days' supplies. Now, while fewer trips to the pharmacy might seem super convenient for the patient, it shifts a massive financial burden directly onto the pharmacy. They now have to purchase and store 3 months' worth of expensive drugs at a time. This completely locks up their cash flow and drastically increases the risk of medications literally expiring on the shelf before they can even be dispensed.
This really illustrates how a flat fee, one-size-fits-all model is just failing everyone. Out in rural areas, pharmacies don't have the sheer volume of foot traffic to make up for those razor-thin margins. And for patients, this means entire communities could lose their only access to a healthcare professional. Meanwhile, urban pharmacies are getting crushed by astronomical commercial rent, anywhere from $25 to $50 per square foot. It's making it nearly impossible to keep the lights on without some sort of volume-based or geographic adjustment.
Section 2. The unpaid care backbone. This is a crucial point from advocates.
Pharmacies are basically surviving by providing a massive volume of essential primary care completely for free. This is perhaps the most glaring misalignment in the entire 2026 framework. A staggering 96% of pharmacists provide over-the-counter consultations without seeing a single dime in reimbursement. When you walk into a pharmacy and ask for advice on managing a migraine or navigating cold meds when you have high blood pressure, the pharmacist assesses your symptoms, checks for interactions, and provides expert clinical advice. They do it because it's the right thing for patient care. But under the current framework, there's no billing code for this. It is entirely uncompensated time.
Let's break this down a bit more to see how it builds. While initial prescribing is covered, meaning if a pharmacist assesses you and prescribes a new medication, they get paid, vital follow-up care is totally ignored by the policy. So when they call you 2 weeks later to monitor your response, adjust your dosage, or troubleshoot side effects, which, let's be honest, is where the real clinical value lies, it goes completely unpaid. The same goes for point-of-care testing like strep or A1C and health screenings like blood pressure checks. The government says it desperately needs to reduce lab wait times and ER visits, yet it refuses to fund the exact professionals who are successfully doing that work right in your neighborhood.
Section 3.
capping advanced patient care. To make matters worse, advocates argue the framework introduces a direct roadblock to the very clinical services our healthcare system desperately needs right now. Looking at the actual Alberta Blue Cross Benefact document, we can see the introduction of a strict $13,000 billing cap per pharmacist for every 28-day period. This went into effect in June 2026, and it applies to clinical pharmacy services regardless of how many locations a pharmacist actually works at. Once a pharmacist hits this threshold, any additional claims they submit for providing care are adjusted to exactly $0.
Advocates warn this $13,000 cap is an arbitrary constraint that doesn't just limit budgets, it actively disincentivizes pharmacists from providing new, necessary clinical assessments once they hit that ceiling. I mean, imagine telling a doctor or nurse to stop providing care on the 20th of the month simply because they've hit a quota. That is exactly what this cap does to pharmacists. It tells highly trained professionals who've invested in advanced credentials like oncology, geriatrics, or mental health that their expanded scope of practice is essentially worthless once a monthly budget is exhausted.
Section 4. The growing retention crisis. The downstream human cost of these misaligned policies is a terrifying retention drain across the entire profession.
You just cannot squeeze a workforce economically, demand their work for free, cap their professional growth, and expect them to stick around. The stress on the front line is palpable. Just listen to this direct quote from a surveyed pharmacist. They feel forced into an impossible corner by the new lists. When you mandate longer supply lists that drain a pharmacy's cash or restrict daily dispensing to only specific opioid therapies, you aren't just changing a spreadsheet. You're forcing healthcare providers to look a patient in the eye and make agonizing decisions between maintaining the financial safety of their business and providing optimal, customized patient care.
Another pharmacist perfectly captures how the cap is actively destroying morale and stalling the evolution of advanced clinical practice. Think about it. Why would a young pharmacist spend thousands of dollars and hundreds of hours getting a specialty certification in anticoagulation management or diabetes care if the government explicitly caps how much of that care they're actually allowed to provide?
Because of this framework, we are seeing a dual crisis. Right now, 51% fear losing highly experienced professionals, while 28% worry young talent will avoid the field entirely. This is the definition of a workforce collapse. Early and mid-career pharmacists are experiencing severe burnout and salary stagnation. They're looking at the 2026 framework and realizing they're expected to do more clinical work than ever before for less real-world pay than they made a decade ago.
Section 5. A sustainable path forward. We must pivot to the actionable steps and evidence-based solutions advocates are bringing to the table. This explainer isn't just about pointing out the flaws. Advocates have a documented roadmap to fix this framework before the 2027 negotiations. These are the necessary remedies they're pushing for. First, that $13,000 clinical cap needs to be eliminated so patient care isn't restricted by a calendar. Second, there must be distinct billing codes introduced for the critical, unpaid backbone of care that's already being done: the independent prescribing follow-ups, the point-of-care testing, the over-the-counter consults. Third, reimbursement needs to be tied to a 3 to 4% annual inflation index so pharmacies aren't slowly suffocated by rising costs year after year. And finally, we need a rural sustainability premium to protect vulnerable rural access and ensure geographic equity across the province.
So here's the big question to leave you with. If pharmacists are the essential backbone of our community healthcare, can we really afford a policy that pushes 82% of them toward collapse? This documented evidence demands a reform of the framework before patient care is irreversibly compromised. We've seen the data. We understand the massive disconnect between what the government expects and what the operational reality actually allows. The 2027 negotiations are approaching fast, and the stakes literally couldn't be higher. Will policymakers choose to properly fund the primary care happening right in our neighborhoods, or will we let the system buckle? Thank you for joining me on this explainer, and definitely keep your eyes on how this critical policy debate unfolds.